Welcome back to Pain Theories Part 3. So here we go, continuing to talk about the mechanisms of the transmission of that pain. So of course we have these interneurons. We have T cells that transmit the cells. They synapse with those A delta and C fibers and the dorsal horn that we talked about because they're afferent nerves. So you can see that you have the source of the pain. Here's that A delta myelinated fast acute pain. Remember, it's got a short onset and it's very sharp. And you can see it coming up here in the blue, and it synapses here at the substantia gelatinosa. Synapses again, and then it goes up through that dorsal horn, and then it heads up and gives that signal to the cerebral cortex to say ouch. Then on the other side, we know that that brick also stimulated the C fibers, those unmyelinated slow fibers that have a little bit more of a long-lasting effect, right? And so here they go again. It's going back through that dorsal horn, synapses, and comes up through the spinal tract, through the brainstem, up through the thalamus, up to the cerebral cortex, and you get that dull, achy pain. And remember, this takes a longer time to get there, but it's going to last a lot longer. So here's the gate control theory of pain modulation. This has come a long way since the first time that they made this theory up, but it's really, as it's gone along, it really does continue to work and allows us to explain why some of the modalities or the physical agents that we use help control pain. And that's what pain modulation is. It's just controlling that pain. So the severity of the pain sensation is determined by the balance of those excitatory, those positives, and those inhibitory inputs to T cells in the spinal cord. And so we know those T cells are those interneurons, right? So here we have the A beta fibers, which we call that non-nociceptive, right? Because they don't cause pain. So that's the non. So you can go back to our medical terminology, hopefully, and remember that means no pain. Whereas here we have the two that cause pain, the A delta and the C fibers. And remember that these both are located in the skin, but the C fibers also have them in their muscle. The A betas are located in your skin. So here they go, and they're synapsing, and you have this excitatory neuron going here, and you have an inhibitory neuron going here, and they come up and they synapse into this inhibitory neuron, and then it goes up to the thalamus, and then it goes up to the cerebral cortex. So what they're saying is because, and this is just would be maybe a sophomoric or a simple layman's term way to explain this to your patients, is that these fibers that are relieving the pain get there faster to inhibit that pain, and they block it, or they gate it, or they close the gate to the perception of pain from the A delta and the C fibers, and they get up here faster and they block that pain for a certain amount of time. So let's say you did a soft tissue massage, or you did some traction or something, and that stimulus, or that non-nociceptive stimulus, is going to stimulate these A beta fibers, which is then going to get there faster and inhibit that, create an inhibitory interneuron, which is going to block the gate here and come up to the cerebral cortex and say, ah, that feels really good. So here it just says this physical agents, which we call modalities, and interventions control that pain by activating those non-nociceptive sensory nerves, which we just talked about. Inhibit the activation of pain transmission cells, which are those A delta and the C fibers, and they close the gate to transmission of pain to the brain, which decreases the sensation of pain. And we talked about soft tissue mobilization is what I like to prefer to call it versus massage, because it's a more therapeutic skilled therapy. Electrical stimulation would also be something that we could utilize in this, and would have this same modulation of pain, as well as traction or compression. And so we will learn that first day of class about cold and compression and how those can work together to kind of help that pain cycle, along with inflammation as well. So I'd highly recommend that you read this part of your book in Cameron, so you really understand what the gate control theory is, what those first afferent neurons are, which ones do what, where they're located, are they myelinated, unmyelinated, are they fast, are they slow, What sensation do they give? Are they nociceptors versus non-nociceptors? If you get all that, you're going to do awesome on the exam. If you have any questions, feel free to contact me. So now we're going to just talk a little bit about measuring that pain. How do we assess that pain? How do we document it? How does that help us in our treatment down the road? So you're going to use to determine appropriate treatment and assess the efficacy of your treatment. So sometimes we do focus on this pain if it's the normal pain from a normal healing phase. When we get into those more chronic pains, the complex regional pain syndrome, we're going to use a different system. But for this, this is basically for your patient who sustains an injury. They're going through the normal tissue healing process where they have some normal amount of pain, and how we're going to assess that, how we're going to assess our treatment's efficacy, and did it help or did it hinder the healing process for that patient, and how is that going to make us adjust our treatment for the next visit. So you're going to assess the cause and the source of the pain. So basically their history is something that happened to them, and you're going to know a little bit of this because you're going to be following the physical therapist evaluation, but sometimes you're going to see them the next day and maybe that pain has changed, or maybe they went out for a run and they increased their pain, and so now you know that source of pain because they went from maybe a mile to 3 miles. So you're still every day going to be asking that cause and source of pain, and the quality of the pain. Was it sharp? Was it dull? Was it achy? Was it burning, stabbing? You know, patients have all different ways of describing with different adjectives their quality of their pain. And we know from these descriptions that can help us know whether the tissue involved is more superficial, like the skin, or if it's deeper muscle injury, or maybe even with the aching could be the muscle, or it could be the viscera if it's more superficial. So it kind of gives you a little bit of a clue as to what type of tissue we're talking about. The intensity and the duration of the pain. And we'll talk about that, and I know you're all familiar with on a scale of 0 to 10. And hopefully you say 0 to 10 and not 1 to 10, because then you're automatically telling them they have some kind of pain. Because some of your patients won't have pain. It'll be more weakness, fatigue. So don't give them those preconceptions. Start with the 0 and go up to that 10. And then how long does that pain last? And how irritable is it? And where, of course, is that pain? Where are you feeling it? Is it very localized? Is it more diffuse? Is it referring? Which side is it on? Is it on both sides? All those kind of things. And these are obviously, you know, these are all things you're going to be putting in your SOAP note. And I would guess that you know that this is going in the subjective, right? Because pain, even though we have objective numbers, majority of it is going to be subjective. And the effect on their function, their activity, and their participation, and that's huge, right? We want to know what can they do, what can't they do, what's limiting them because of this pain, what's their normal activity level, and how is this being impaired, and their participation. Are they able to go to work? Are they able to do the activity that they want to be able to do? All those things are important to know what to do. There's our numeric scale we talked about, and then we also have a visual analog scale for those patient populations that aren't able to express to us in a 0 to 10 scale. So we have this nice little acronym that we use when we're trying to remember and include in our subjective note all the different parts of pain. So you have P for provocation. So those are the things we're talking about, the causes, what makes it better or worse. The Q, the qualities, so that's describing it with those adjectives of dull, achy, sharp, burning. Referral is just basically the same as location, so where is it at? S is the severity, that's that 0 to 10. And timing is like how long does it last? Is it better or worse in the morning, better or worse at night, better once you get moving around, certain times of the day, or is it all the time? And then how long does that pain last? And then there's that visual analog scale that you could have, you could give to a patient, tell them, okay, just mark on here where your pain is. Currently, I sometimes ask them, what is it today, right now when you're here with me? And then they'll mark on here what it is. And then I'll ask them, what is it at its worst? And then they'll mark that. And what is it at its best? And so sometimes you'll have 3 different slash marks because it'll be at 3 different times depending on when they come in to see you, what they've done that day, have they taken pain meds, all those different variables. And then here's another one I think you guys are familiar with. Use this a lot with children or people maybe who don't speak our English, or maybe somebody who has a processing issue. So you can tell them, you know, the smiley means no pain versus, oh, I'm having a lot of pain. Okay, I'm going to keep going because this one's almost done, so bear with me. I know this one's a little bit longer. So physical agents are what we call modalities. They relieve the pain by moderating release of those inflammatory mediators we talked about. They modulate the pain at the spinal cord level. They alternate that nerve conduction, which is really important to remember. And they also will do it by increasing some endorphin levels. Now, the reason those endorphin levels, that's going to be a whole other pain theory that we'll get into a little bit later. You won't need to know that for this first exam, other than that this is something that a physical agent can do. The different methods, we have cryotherapy, which are most, you know, we use ice massage, cold pack, ice pack, maybe game ready, like a vasopneumatic compression with the cold. Thermotherapy, which is going to be like heat, ultrasound, paraffin, anything that heats up the tissue. ES stands for electrical stimulation, so that could be a TENS unit, which is more a setting for pain, or an interferential current, which you can use for pain or for swelling. And obviously if you decrease that swelling, you're going to decrease the pain. And then we also have traction, which could be mechanical with a machine, or it could be us doing it manually. So all those things are going to help with that. Advantages, you have fewer side effects. You know, when we take medicine, there's lots of things that it can do, side effects it can cause. No localized adverse effects. You don't develop dependence on it, you don't impair ability to work or drive, and you can be used independently. Now, when we're talking about this, we just need to remember, and we'll talk about this when we do our videos on cryotherapy and thermotherapy, that after they've had cold therapy or heat therapy, those muscles do lose some of their ability to emit force. They're going to be a little bit weaker. So you're not going to want somebody to go straight back to a physical activity for at least 1 to 2 hours afterwards in order for them to get that back. So the treatment of chronic pain, that's a multidisciplinary approach. It includes exercise, it includes those physical agents, education, counseling. We get occupational therapy, cognitive behavioral therapy. We've started adding mirror therapy. I know they're doing some virtual reality things also with chronic pain with some huge success. I'll try and post a TED Talk for you down the way. I know you have a busy week this week reading all this stuff, so I'll probably just put that on there for your leisure at another time, but there's pretty cool stuff that's happening out there. And that's the end. Thank you.